Welcome to the Sultans of Sales podcast. I'm your host, Jamil Pendleton. Friends call me Jay. Today on the show, I'm excited to bring to you Dr. Fred Ogden in New Jersey. Dr. Ogden is the Chief Medical Officer of Neurosurgeons of New Jersey, one of the largest neurosurgical private practices in the country. And we were talking a little bit before we pressed record. Dr. Ogden, I know it's a little bit unconventional, but hey, it's podcasting in 2022. I'd love to give you the opportunity to formally introduce yourself, because I'm not going to do nearly as good of a job as you are. You've got so much background with your kind of where you went to school and kind of everything like that. So if you wouldn't mind, first off, thank you for joining the show and welcome.
Yeah.
You bet.
Yeah, Jake, it's great to be here. I'm a big fan. I think there's a lot of interesting stuff in spine and neurosurgery to talk about. So I'm a private practice guy now, and our group is all over the state of New Jersey. We're the biggest group in the state and one of the biggest groups in the country. So we integrate spine, intracranial, endovascular. But in the private practice world, spine is really big. Really important to us, and it's become a focus, and that's part of the reason, probably why I'm the CMO for the group. But I've recently left academia, so I trained at Columbia, and then went away for a year to Northwestern for a spine fellowship after training, and then came back in 2008, and I just left a little over 2 years ago. So I was on faculty at Columbia for over a decade.
Right.
So I got, some perspective from that and to what I'm doing now. And it's kind of funny when I think about, like, when I went back to the Neurological Institute at Columbia, it was, this old kind of dark Art Deco building.
Right.
And I very much had a traditional type practice where I was kind of like me, and, I had my assistant, the residents, the whole way things functioned, very sort of old-fashioned hierarchical system to what I'm doing now, what we're trying to build, and we're in a way that we're able to build it, I think, because we're in private practice, not part of a big institution. It's been a really interesting journey, and when you marry that kind of change of perspective and change in the way we're delivering healthcare, and just kind of associating with not only with our colleagues but with patients, you marry that with what's happening in the world from a technological standpoint, both from an informational standpoint, software standpoint, smartphone standpoint, and then of course all the stuff that's happening in the OR. It's a really exciting time.
I mean, gosh, that right there, what you just said is the framework of a great conversation, because your experience at Columbia, the large teaching institution, right? All those things, which I'm sure you draw from, right? Every day, yeah. I would imagine. And then you mentioned two words that I wrote down: journey, perspective, and then how you're delivering healthcare today with the technology available. So what would you say? Like, what is, if you're thinking about what you do today, right, for your practice and for your patients in New Jersey and in the greater surrounding, tri-state area, what would you say is the biggest difference, or maybe a lesson that you learned in private practice that you could share with the audience?
Yeah, I think that, from private practice standpoint, it's really about focusing more on the patient experience and trying to demystify surgery for them. You think about the way that the traditional spine surgery was done. Big open surgeries. Traumatic surgery is hard to get over. You think about, like, the patient perspective of, you're sort of mysteriously going to see this doctor. They say you need this big thing with these screws and rods put in, and you go in, you have a big surgery. You're in an academic center. Your roommate, might have some, neurological disease, and it becomes, I think it's a traumatic experience, or it has been a traumatic experience for patients. I think it always will be, to a degree. I mean, they're coming and having surgery, but I think, in the private practice world, you're kind of, you're closer to the patient in a way, I think, and at least you can be, if you choose to be, and you're able to take that information, and try and make it a less mysterious, sort of better experience for them.
And how do you do that? How do you demystify? I wrote that down too, because that's exactly what you're trying to do. I mean, these people are in pain, they're scared, and you've got the opportunity to help them. But as you said, you have to put it into the way that they can understand, consume, and then have the faith to move forward with the plan. So how are you doing that?
A lot of that is communication and giving them information. So you hear a lot about the advanced recovery after surgery, ERAS protocols. There's a lot of great in-hospital stuff that that takes place, but there's also a lot of preoperative educational stuff, right? So that they have an idea before they even come to see you, what their condition is, what the possible treatments are. Like the worst thing in the world would be someone who comes in and they have no idea. Everyone's had this experience. They don't know, they've been referred to you, right? They don't know what they have. They don't even know that you're a surgeon, and you spend all this time telling them, you explain them what they have, you bring up surgery, and then, they're not even thinking surgery, and now it's surgery, and they need some big surgery or something like that. Like the worst scenario with that's unfortunately still happening sometimes. Someone comes in with metastatic cancer and they're being referred to do they need surgery for their cancer, and they don't even know they have cancer, right? Yes. So that's pretty uncommon in the outpatient setting, but not uncommon in the inpatient setting. So the point is that before they come in, they have some idea of what's going on with them, what the possible treatments are. So then you bring up the topic of surgery, they had a chance to think about it and digest it, and then it's your job to really talk about why it needs to be done this way and how it can be done in a way that may be less traumatic. And then part of it's also just they know what to expect. Okay, you're going to a hospital or an ASC. This is what it looks like. These are the different players there. Again, so it's not sort of surprising, and with COVID stuff, unfortunately, we're in COVID time, you're not gonna be able to bring a family member, all these things that, aren't really foremost in our minds because we're so focused on the task at hand and surgery, but yeah.
Well, that's really interesting because I think that it's, as you said, the time in the market now with telehealth and with COVID kind of speeding some things up, changing the rules a little bit. And also given the fact that you're demystifying, you're educating, you're kind of doing a lot of expectation management up front, which I would imagine leads to just more clarity of the process involved. Mm-hmm. Have you seen that as a direct correlation? And sorry, this isn't anything that I sent you ahead of time. I'm just thinking, have you seen this as a direct correlation to PROs and the patient-reported outcomes? I know it's coming.
Yeah, I think that's a big piece of it, right? So, and I would sort of take it a step further, right? So instead of historically, I would do a bunch of surgeries. I wanted to publish it. I would say, okay, this is did these surgeries, and everyone did great, right? Or good outcomes were good, right? And so people realized that wasn't worth much, right? Mm-hmm. So then patient-reported outcomes became sort of standard in terms of publishing. Ask the patient how they're feeling doing it, and do it with a standardized questionnaire that's been validated to actually mean something, and figure out what a significant difference is or a clinically meaningful difference. So it's a good start, right? Mm-hmm. But there are ways now actually on the technology front. There's a company that we're about to engage called CareSense that sets up a real-time dialogue between the office and the patient using apps, and that software can speak to the information systems in the hospital. Oh, wow. And it also has all the outcome stuff. So you can start to get really granular in terms of the variables that you can manipulate in the hospital. And see what the results are, and make little changes and track them. So I think that's kind of where we're headed. Instead of a cumbersome, you have this theory, we'll change one variable, do a big study, to get a more kind of a continuous feedback loop. And it doesn't take the place of telephone calls from the office; those are important. But if you think about it, like again, going back to when I was at Columbia, I had one assistant. They would make one telephone call to a patient. Let's say the patient wasn't there. Okay, so patient calls back, my secretary's in the bathroom, right?
Right.
Just it might take 36 hours to get one piece of information. And that piece of information might be something, not so important, and all this time was spent on it. So
That's right.
So there's gonna be a revolution coming in terms of that. It's already starting to happen. But I think that'll make things really interesting. And then just to kind of feed back into the OR, which is, where all our hearts are, we have these ideas about things that we want to change. We can actually see kind of what the results of those things are, whether it's a new medicine, new piece of equipment, I'm using this type of anesthesia, this drug, right, post-op to control pain, whatever it is.
That's awesome. That's fascinating. Cause I mean, I think, there's been a behavioral shift in how people consume and how they make, decisions, buying decisions, right? But decisions of consenting to surgery is certainly a big one. And if you guys your practice can use, the latest technologies to keep them informed, educate, and just kind of that up on demand when they need information. As you said, it may not be extremely important, but it's just the access to it, which is changing. And I think that's really, really interesting. Well, thanks for sharing that. And what a great perspective you must have, kind of given all the things, that you've seen across your career and are seeing. What about, you mentioned the OR, and let's talk about that. Let's talk about because as a private practice physician and doing a little bit of homework on you, it seems like MIS and minimally invasive spine is kind of something that you've that would categorize your practice. But I don't want to speak for you. Can you talk about what you're doing today, the OR, and what excites you maybe about the future of spine surgery?
Yeah. So I think that the distant future, I think, will be a sort of biological revolution, but we're not there. So if you think about the goals that we want to achieve in terms of what we're doing with spine surgery, nerve decompression, fusion, correction of deformity, they're really kind of the same problems, and we have a lot of conceptually the same solutions. Some of that's changing, but that largely hasn't changed since I went through my training. But what's really changed is how we do that.
Right.
So it's the minimally invasive revolution, the advent of neuronavigation and robotics, and the ability to perform more and more complex surgeries in a less traumatic way for the patient, figuring out ways to get patients home faster, something whether they even need to be in the hospital. And so you can think of that in terms of sort of the first big thing is the use of a tubular retractor, small incisions, to identify in a very pinpoint fashion the area of pathology, the surgical focus, surgical target, right? So that came along a long time ago, so let's say 10, 20 years ago, right? But that's been expanded to get to harder places. So neuronavigation, again, been around for a long time. Robotics are coming along, but that's really just kind of another way to more precisely place instrumentation. So using smaller incisions for that and higher accuracy. And I think that the next kind of piece of this that's happening now is visualization. Okay, nice. So if you think about, if you're operating, let's say you got a long case, you want to be in a very comfortable upright posture, right? And so traditional spine surgery is operating like this for hours on end, right? Exactly. That's not good for you. That's not comfortable. You can get around that in some cases by using a microscope. Okay, so you're looking straight into the microscope, and the microscope's looking down for you. But the problem with that is you still have to angle it into the direction of the line of sight. Right. So it saves you this, right? But it doesn't save you this.
Right.
You know what I mean?
Yeah, so, the limbo,
Yeah, right. Gymnastics. Yeah, this, and every time you change your view, you have this big clunky thing in front of you that was really actually designed for brain surgery. Where they don't move the scope around. I mean, it depends on the case you're doing, but that's really more of a change in kind of focus and little movements. Right. So, and so you think about a spine case where you have to move that a lot. and you're also bringing in instruments that are kind of bigger. It's not all microsurgery because you're putting in instrumentation, right? It's not the best tool. So the visualization revolution that's sort of happening, and I guess in a way I'm predicting is freeing you from all of that, right? So it's having a camera that looks for you, that you can put at any angle you want, and the only angle you have to change is, my hands in there, the angle of your hands, right, instead of the angle of your head, right? And I think that makes you a better surgeon. It's a transition that can be hard because people are used to either using their eye, binocular eye vision, or microscopy, and so the technology now, a lot of it is 2D or enhanced 2D, and that'll change eventually. And the other thing that does for you is it frees up a lot of space. So if you think about the integrated OR now, right? You've got your robot, nav situation. You have whatever kind of fancy tools you have.
Right.
You don't want a big kind of bulky thing. So if you can have like a little camera that does the viewing for you, and the screen's over here. By the way, you're looking at other things on the screen too. You're looking at your nav, you're looking at, the MRI or the CT or whatever, right? So you think about an uncluttered, or as uncluttered as possible, integrated heads up operating environment. That really excites me.
That's exciting. And I mean, I certainly don't want to make this a commercial for my employer, but I mean, it's exciting to know, we haven't met formally, Dr. Ogden, but it's exciting to see kind of from some of the things that you've done and are doing in your practice using Vision, using the camera that you're mentioning, which fits proximal, which shows you below your hands. I think I've seen some things like this in my years standing in these ORs, but I haven't seen anything like it at the same time because of what it's an unobstructed view. That's where I'm going with that. So thank you for explaining it in such a great way in terms of the visualization of revolution. I would agree with you. What is this doing for you today? What is this enabling? When we talk a lot about enabling technologies as an extension of these minimally invasive techniques, or as you mentioned, navigation and robotics, what is Vision enabling you to do in your practice?
Yeah, so it's a good question. What I would say is that, and by the way, it's not just Vision, right? So there's Telogen, is a product it's a Pew product that's going to be on the market. I think it's available, I believe, sometime this winter to its development users.
Cool.
And will be available. And there are some other products that, we could go into that do the same thing that, maybe have some drawbacks, but sure. So I think this is a technology that's coming up a lot of different places.
Absolutely.
So that's the first thing to mention, but I would say, what we're working on now, what we worked on initially was just doing some of getting the low hanging fruit in terms of, not sort of going into a new surgery, but an older surgery. So, decompression, or particularly MIS TLIF is the case that, I've probably done 30 or 40 using technology. And what I found is that the visualization of particularly the grafting part of the case, putting the cage in, you can just see better for the reasons that you raised, right? You're not looking around the handles of the instruments. You're not looking around your hands, right? It's the shaft and the instrument down, and that's true for XLIF as well. So that part of case where you're putting the end plate cleaning instruments on, when you're putting in the templates, the trials, the cages, you can see that part a lot better. I think that for XLIF in particular, there's some things that I've seen more easily, I think, than I would have with the blind eye, because that's a case where really pretty much everyone does that case through loops. There may be some people that use a microscope, but you can imagine loops, and that's a very long tube. So you're really kind of far away from the target with the loops. And I don't think it's a case you see that well. Now, people might argue that you don't need to see that well, but you do need to see. And so the other benefit, at least with XLIF, that I found with this, is that you don't have to move the fluoroscope in and out. So that's a very
That's right.
fluoro-intensive case. You need to sort of check constantly where your instruments are using fluoro. And you can just leave the fluoro in, since you don't have to look down the tube. You can just reach over and operate, and so it saves time and energy there. And then the other thing that it's sort of the next sort of step from this in terms of XLIF that it's I think going to be huge for is prone XLIF.
Yes, the prone laterals. Yeah, absolutely.
Yeah, but prone laterals, not just XLIF, right? Whatever, OLIF, any sort of prone lateral situation. And the reason for that is obvious. The patient's kind of down here, and you're looking, the patient's flat, you're looking like you need to look like this. So you either have to tilt the table, you have to raise the table and operate like this, which is not comfortable, or you have to bend down, right? So not having to look down the tube and being able to do the case without looking down the tube, and that situation is a real no-brainer.
Yeah, no, I can imagine that. I've seen these in the OR, kind of visualizing the prone lateral and kind of showing on that high definition screen. It makes a ton of sense. And so thank you for that, because it's exciting for us, at least for me. I've been in spine since 2008, seen a lot of advancements. And Dr. Uribe and I talked about, it's a lot of times it's incremental steps that really, as you said, as you're putting it on something, it's just a slight change or a slight enhancement that enables other things. And so I think that's truly what enabling technology is. Would you agree? I mean, what are your thoughts on that? Like what it could do for spine surgery or for your practice? I mean, I don't want to get ahead of ourselves here, but
no, but it's 100%. So I think that the prone lateral is a really good example. And I don't know how much technically you want to get into the weeds with this, but
wherever it's your show, man. You're the guest.
So like, what I do a lot of and like doing are, if you have like a low segment deformity, the lumbar spine, so let's say you're looking at, accomplishing like an L3 S1 fusion, right? And, and so you're looking at it like, okay, how do I want to do this? Because of the deformity, it'd be nice to put some lateral cages in. Can I get, I'll do 3-4. Can I get 4-5? Do I want to do it lateral, then prone? So am I going to do teal? So what's my surgical plan? So you think about like, okay, prone XLIF, if that becomes an option that's palatable to you, because you can use a camera to see, right? I don't want to do a prone lateral because it's uncomfortable, whatever. But, I got the camera now, so I feel comfortable with that.
That's right.
So then you can look at it like, I'll just put the patient in the prone position. I'll probably be able to get L3-4, no problem. Hopefully I can get 4-5, because I'd like to have that leveling action of the lateral.
Exactly.
And get the bigger cage and et cetera. But if I can't, I'm already in the prone position. The hips in the way anatomically or whatever. I don't feel comfortable. I can bail on that. I'm doing a 5-1 T-lift anyway. Right. And now I just do the T-lift. The patient's in the prone position, right? So it puts you in a position where, okay, well, I'm going to try the prone XLIF. And instead of just saying, okay, I'm just going to do it.
Right.
Yeah. You might have someone that might just say, okay, I'm just going to do it open. Right. Because I don't want to deal with all that stuff. Right. Or I'm going to do it, I'm going to do a flip. So I think that's just, one example of how you're right. An incremental change then shows you, okay, I'm thinking about these things differently now.
Right.
And it actually changes your whole surgical planning.
Well, and I'm sorry.
Go ahead. That's it. Yeah.
Well, just because you hit it, I was going to say, I was about to say, there's a lot of talk about surgical planning, right? Preoperative planning and having that. Obviously, we all know about the relationship between lumbar lordosis, pelvic incidence, and then there's a whole host of other, parameters that I believe started in deformity world, but now it's just spine surgery in general, the alignment piece. And a lot of times that plan that you have needs to change based on the anatomy. So the iatrogenic stuff that happens, or really just, as you know, as a surgeon, things change, plans change. And I think what you mentioned just a moment ago, which is really key, is having the intraoperative flexibility to deviate from maybe your plan or from the diagnosis or kind of like how you were going to treat that patient, but you're not really losing anything. You're just pivoting to a different option. And that's powerful.
Yeah, no, I think you're right. I mean, I think generally the concept with prone lateral is one important concept is if you want to do a patient in the prone position for whatever reason, pick your reason, right?
Yep.
This brings lateral in as a tool for whatever prone case you're doing, however you want to do it, and the camera enables that. So even if you're an open surgeon, right? Let's say you don't do MIST lift, right? Let's say you do some laterals, and you like the results that lateral gives you at a particular segment, and you want that in your long segment posterior construct. Well, you might not do that because, I don't want to, it's going to be too long
the flip
anesthesia time if we do the flip, right? So I'm just going to do it all in the back, off and back. Well, maybe you would have gotten a better result, had you done it that way, at least, radiographically, or you would have been happier with it. And so anyway, or maybe not, or maybe something happens to your point during surgery where you say like, oh, wow, lateral would be great here, and then you have the ability to do it,
Yeah. You don't limit yourself based on, the inability or the inefficiency. I mean, you've mentioned a lot of key pearls. I think ergonomics are important. Visualization, obviously, there's some efficiency plays. What about like safety or, you mentioned the ASC setting. So I kind of want to round out with kind of site of care as it relates to what you're talking about right now in enabling MIS and just kind of where you see this all going. So just kind of however you want to answer that. It's not really a very well-structured question. It's just more of a kind of your thoughts on where this goes, site of care, or kind of how you're treating your patients today versus tomorrow.
I think a lot of this is a movement to ASC. So doing bigger cases there, doing cases that maybe aren't so big, but in older patients and putting the systems in place for that. I think that in terms of specifically using a camera for that, probably the main thing it enables is the ability to sort of get rid of the microscope in those settings to actually not have to get one. So it enables the dissemination of some of these surgeries, fusion surgeries to ASCs more readily. Right. Unlike some of the other technologies where it's a big upfront cost, you can try it and see if you like it, so I think that's a big thing. I think that it's amazing to me the impact that carefully considering the preoperative intraoperative medicines and the postoperative medicines in terms of long-acting local anesthetics, how if you have all that stuff set up, patients can get home a lot faster and don't need the overnight stay in the hospital. And there's so many benefits to that. So there's the comfort of being home. There's the mobilization that happens that doesn't happen in the hospital. I can just tell you from my own hospital experience, at night, it's like someone comes in for a surgery, and it may be a tiny surgery. Maybe they stayed because, I don't know, they have some heart condition. You want to watch them on telemetry, let's say. Sure. And like getting the hospital to get that patient out of bed is really difficult. And I understand why they have staffing issues, especially now with COVID, and the last thing they want is someone to fall, at night, et cetera. Absolutely. But, if you make the decision that they can go home, then, they're home and they're getting out of bed and moving around. And so I think that's like the back end of what we were talking about before in terms of the expectations is getting them back to normal faster. And that's so important psychologically for everyone, particularly for older patients, though, get disoriented in unfamiliar environments.
Absolutely. And movement is such a key part of getting the patient back post-op. And to your point, it's the expectation management up front. You have all these all these tools, all these ways to communicate and carry that discussion and inform them along the way. You go into the surgery, you've got all these new potentially groundbreaking enabling technologies. You've mentioned a lot of them. And if we could do that collectively as a market in the surgery center that has, right, the patient in that mentality of getting up, getting back, and, recovering, that's the holy grail. We're not there yet, but you can see a little bit of, the movement. It's exciting. I mean,
Yeah.
What has your ASC experience been like? Because I think you've seen it all. You've seen the large institutions, the private practice, and then now kind of like you're talking a little bit about like where these procedures are happening. And, could you comment on that or?
Yeah. So I am fairly new to the ASC game. But I am an ASC now, and right now we're in the process of putting our TLIF program together, putting it together our larger segment fusions. So I think the feedback you get from patients from the ASC experience is much better. I think they it's hard because what I actually go back to is I think back to like when I was a kid and I would visit patients, in the hospital, and right. I think most people don't like being there. It makes them makes you feel like a sick person. There's and most people that are coming in for elective spine surgeries, they aren't. I don't think of them as sick per se. You think of them as they have like a neurological / right. orthopedic problem. It can be fixed, and they're people that are healthy, sure. and they've been a little derailed, and so I think that having them in a different place makes sense. I think that they feel better just not being routed through those environments.
No, that's well said. No, it's exciting. And really just, I'll close. If you got time for one more question, I know I've taken up some of your time today. So thank you so much again. What do you want? I mean, this is a big question. It's just your legacy. I've been thinking a lot about this. I'm a dad. I'm looking at, what am I leaving behind? But just for your perspective, what do you want your legacy to be?
So I could probably encapsulate it like this. I would like to, be a force for good, in the spine community. What I mean by that is hopefully to have an impact on practice patterns that is the following. It's a system where, people that are having surgery have it because they need to have it, right? No other reason. And, within that are, maybe, a lot of patients that have gotten through their problem without their having surgery. Okay.
Right.
And then if they do need to have surgery, getting them through that in the least traumatic way possible. That's
great. And it sounds like, just from my perspective, having this discussion today, and then from what I've heard, from those that have been in the OR with you, that you're well on your way to building something there pretty special and pretty lasting. So, Neurosurgeons of New Jersey, if anyone wanted to find out more information about you or about the practice, Dr. Ogden, where would you send them?
Yeah. So to the website, it's not memorable, but it's easy to remember, I guess. Neurosurgeons of New Jersey. And we put a lot of time into our outreach to patients. And there's a lot of, even if you're, in Honolulu, whatever, there's a lot of good information there. And great. It's meant to be a resource for everybody. Yeah.
That's awesome. Well, thank you so much. Maybe next time we do this, if there is a next time, we can dive into marketing yourself as a private practice physician, right? That's another podcast, and it's a big topic these days.
Yeah. Yeah.
So, well, thank you again so much for joining. Look forward to seeing you in Las Vegas here in a few weeks.
Yeah.
We're going to be doing a panel discussion talking about enabling technology and a lot of these topics. So this is a really good opportunity for us to come together, and appreciate you sharing you know, your wisdom with the audience and with me here on the Sultans of Sales. So
thank you, Jay. It's been a pleasure.
Yeah, it was good. Yeah, we'll close it out with that. And thank you all for joining this week's episode with Dr. Fred Ogden. Tune in next week.